Vice-Chancellor of the College of Health, Medicine and Wellbeing at the University of Newcastle. I'm delighted to be here today to open the third session of the Value in Health Economics and Policy Forum at the Newcastle Business School. Today's session has the very intriguing title of COVID-19, a tale of carrots, sticks and megaphones. I'm sure that all of us have been following the evolution of the COVID-19 pandemic over time, from the development of tests, then vaccines, the emergence of variants, together with vaccine hesitancy, and observing the various wait and see versus firm hand approaches that have occurred in Australia and globally. I myself moved back to Australia in May after 6 years of working in Singapore, and yes, just in time to experience lockdown here in Australia after having had 18 months in Singapore. I've been amused and bemused by the different approaches in both nations, particularly in terms of communications and compliance with restrictions and public health orders. I think we have all seen the massive challenges associated with ensuring effective communication and reach, as well as managing the significant effects on mental health and wellbeing, and recognise that this poses immense difficulties for peoples, industries and policymakers navigating this second year of the COVID-19 pandemic. Today, we will hear from a distinguished panel of experts and global leaders from industry and academia who will share their insights, which I'm also very keen to hear. I will now hand over to the chair of the forum, Francesca, the Professor of Health Economics and Policy at the University of Newcastle. Please join me in welcoming him.
Thank you, Professor Upton, and welcome everybody. This is the third meeting and forum that we have on COVID, and as Zee pointed out, on the tales of carrot sticks and megaphones. So we're almost 2 years since the pandemic started, and we couldn't be more delighted. I think today we have a very distinguished and excellent group of speakers today, starting from Francesca Colombo, who is the head of the Health Division at the Organization for Economic Cooperation and Development, the OECD. She has worked many years in leading international activities on health and health system. Formerly, she seconded the Ministry of Health and Labour of Guyana as acting head of the planning unit, and was instrumental to the implementation of financing and governance reform of the health system. And in fact, that's how I met her almost a life ago, when she was working on private health insurance reforms, in fact, in the OECD. Very well crafted and developed report that was inspiration, I think, for on many projects globally, and certainly on development of policy globally. I'm delighted to also introduce you to Mark Fitzgibbon, who is the CEO and Managing Director of NIB, which is a Newcastle based company, but since Mark started in his capacity, the firm has really flourished globally, with activities in several countries, including New Zealand, China, and so on. And as being a pioneer in the industry and an advocate for many innovation in the regulatory side of health insurance, advocating for, of course, for better health and better health access, he has been recently also pioneering new forms of work by introducing innovations in that area. So welcome, Francesca, and welcome, Mark. I would like also to introduce Professor Jim Gillespie, who is from the University of Sydney and the Health Policy Menzies Centre for Health Policy at the Sydney School of Public Health. Jim has written very important contributions on the governance and the systems that surround the organization of the Australian healthcare system, if we can call it as such. We will probably touch upon that later on. And of course, he has been recipient of numerous grants from government in all areas that really are of primary focus for the healthcare system in Australia. Of course, primary care is one of the areas in which he has worked quite actively in recent times, and of course, again, the role of public-private mixes and comparative healthcare systems. Finally, Professor Podger, who is a professor of public policy at the Australian National University. Andrew has been a long-term public servant before joining the academia. He served as a public service commissioner, secretary of the Department of Health, and secretary of other departments of health at the Commonwealth. Andrew has been an intellectual asset for the Australian thinking around organizations, structures, and design in multiple occasions. When we met, it was the time of the National Health Hospital Reform Commission, and I started there appreciating the contribution to the thinking around healthcare and healthcare systems organizations. Now, welcoming you, everybody, I would like to start this conversation with our panelists. And before I do that, just some housekeeping information. This is a recorded session. Obviously, in our TV, YouTube TV channel, so to speak, that there are often very vivid debates that happen afterwards. So we will keep in mind also the people that are connecting afterwards. For those who come in and out of these sessions, please feel free to direct questions to me. Just put UQ for urgent questions if you have a question that can be dealt with towards the end of the session. Just put Q in front of it, and I will do my best in going through all the questions, or as many as we can. Now, welcome again, Francesca. I see you are in winter, so also thanks for the early start for you today. As you know, here in Australia, we're just coming out of lockdown. In some parts of Australia, this has been the longest ever recorded, over 250 days for Melburnians. Now, that in and itself is a disruptive event. So COVID certainly, but also the consequences of it, which come from government intervention and so on. And partly there has been an increasing argument, or at least a conversation starting also in light of the Monti Commission report around the fragilities of our healthcare systems and possible ways forward. Some going in the direction of supranational increased authority or better coordination, some discussing models that we know for a while that are all referring to One Health and things that are clearly sound in theory, but then healthcare on the ground has many complexities and silo-based approach. Can you let us know what are your thoughts from where you sit, and what you think are some steps, concrete steps that we can keep in mind and work on in the developed and developing world? Big question.
Yeah, just a small question to start with, and well, good afternoon to you. Good morning for me. It's still dark here. Light is starting to come, and yes, we are in winter, as you were saying. Look, Francesca, it's a huge question that you're posing, but I think there are many dimensions to it, and there is definitely both a global dimensions, but also more domestic and even local dimensions that it's worth addressing. So let me maybe first start from the global dimension. I think there is globally, obviously, a very clear realization that COVID-19 has been incredibly disruptive, but that's the health, the scale and intensity in this past few months and past couple of years. And so we have seen now, and you alluded to one of them, the Monti Commission review, but we have seen a number of different reviews which are being launched, and many of which have also been concluded that focused really on the strengthening more of the pandemic preparedness system for the future. And, obviously we have the PPR review that was led by Helen Clark, former Prime Minister of New Zealand, but also by Helen Sirleaf, who was the former president of Liberia. We have the G20 high-level independent panel on financing the global commons for pandemic preparedness and response. We have the Monti Commission that you have alluded to and just released yesterday or the day before yesterday. We have the new global preparedness monitoring board that looks at moving from world apart to strengthening worlds which are united. And there are some common things in terms of the global aspects which come across those reports, which are really looking at the need for improving the global financing for pandemic preparedness, and also changing the global governance system. So whether creating a new health threat council sitting within the UN, or issues creating a new global health threats board and a new financing mechanism, or in the Monti Commission specifically, the idea of having a new global health board situated within the G20 again, and the Global Preparedness Monitoring Board talks about collective financing mechanisms. So that's the global dimension. However, and that's where I'm moving them more also to the more domestic and local also dimension. All these reports rightly very much called for strengthening the investment in pandemic preparedness and report, but we cannot forget that no amount of investments in pandemic preparedness and in being ready for an emerging threat will stop future pandemic if the underpinning health systems are not fit for purpose. And that's what we have seen across many OECD countries. Obviously, Australia has been a tale in itself, New Zealand, of course. But what we have seen that a number of countries were just very unprepared in terms of the structures, in terms of the governance, in terms of the financing, in terms of the delivery at their own domestic level as well. And so if you don't have strong, resilient health systems which are able to respond to an unexpected surge in demands and an unexpected health crisis, then no amount of financing for pandemic preparedness will make sure that you are ready to face this crisis. And here we're talking obviously about things which are not new, but perhaps in a way we have not made sufficiently move in the right directions. Starting perhaps, well, three things maybe that I want to put on the agenda for the discussion today. The first one is clearly the importance of strong primary healthcare. What we're seeing the pandemic is that they're both the front line of the pandemic response, but at the same time, they need to continue to provide that usual care and normal care for other people which are not directly affected by a pandemic, but that do need care in order to sustain their lives. And we know that financing and organization of primary healthcare is particularly weak across countries. Secondly, it's quite clear, and we've seen it very much eloquently in this pandemic, that the people who are most badly affected are those who have underpinning chronic conditions, those who are weak in a way. And we know all too well how financing and spending for prevention and public health is really, really tiny across OECD countries. We've said it for many, many years. It's only 3% of total health spending, which is devoted really to improving the resilience of the health of populations. And thirdly, there is an issue of the health workforce, which has been not just under huge pressure in a number of countries, but we know, and we know it for time, how there is a shortage of trained and inadequate number health professionals. We've done actually some, I say it a little bit heroic estimates and calculations at the OECD of how much it would cost to have more resilient health system to face future crises. And we came with a figure on average of an additional 1.5% of GDP that would need to be injected in health system to make them more resilient. And the 2/3 of that, about 1% of GDP additional spending then going to health, is actually going to train, retrain, and also strengthen the skills of the health professionals. So I think the investment case is clear, and there is, as I mentioned, both a global investment case dimension, but also a fundamental issues about financing properly universal and high quality health services. I'll stop with that.
Thank you, Francesca. Just to continue this conversation, I think there are a few points that I take home from this. Clearly, the fragilities are out there, and now they are recognized. Many have recognized them, and there is this call, in a sense, what we can refer to call for additional support, right? So. And the estimation is significant, and of course, different countries will have different ability to respond to that call, and also different organizations to receive and be able, in fact, to sort of participate to the discussion on how we should sort of regroup and think about improving the responsiveness going forward. Now, in Australia, but in many other countries, what we have observed, it's been, in some sense, some analysts have described it as a takeover of the private sector, at least in the moment of the crisis. I remember when I was actually in Italy, just arrived in February, it seems ages ago. Basically, very quickly, the private hospitals were sort of borrowed, and that didn't necessarily mean that they were equipped to do the job that they were asked to perform, right? So now here in Australia, of course, similar responses were in place or occurred, and the private sector has been a player in the response to COVID. And now, of course, there is the problem of getting out of COVID and seeing what is that its purpose is. Now, naturally, it's still serving the services of the public sector, absorbing the demand for things that couldn't be done before, or elective care catch-ups and so on, creating some bottlenecks here and there. But now, this organizational structure that we have here, Mark, which is the public and private coexisting, can it be improved in its form of collaboration? Do you think there are better ways and more sustainable ways that can also sort of align with what Francesca was saying in terms of strengthening our system going forward? So perhaps even our responses in terms of lockdown and things like that can be calibrated different. To you, Mark. Thanks.
Yeah, got it. I think I know by now. I'm only on this 24/7. Yeah, thanks, Francesca. And as Francesca commented, it's a rather big question. Just a few thoughts to share based upon your opening. While it was, and for those who are not familiar, as Francesca mentioned, the public system basically requisitioned the private system to cope with what they expected to be a surge in demand for hospital beds, ventilators, and ICU. It turned out not to be the crisis that some had predicted. It was still ugly and deadly, but not as bad as what it could have been. And while the government taking over private hospitals has inconvenience and some negative consequences for those with health insurance, I think as a civil society we accept that, well, that's tough. We have to treat people, based upon triage and based upon need. And if there are bed and workforce and nurses and hospitals and ICUs available, it doesn't matter whether it's public or private, that's the way it should be. And we believe in that. But it has had the consequence of postponing or deferring a lot of non-emergency elective care. One of the interesting features of that I'm finding, and there's research is the evidence is starting to emerge, particularly out of the USA, that while because of that, we've lost a lot of warranted care, care which should have occurred, such as, early detection of cancers. At the same time, we've lost a lot of unwarranted low value care. So it'll be interesting to see how that plays out in the future once the pandemic becomes endemic and things normalise. Do we see a slight shift in the trajectory of healthcare activity and growth and spending? We know since World War II, across the entire OECD, healthcare spending has grown at a rate of GDP plus 2%. Does that equation change slightly? Or does the system become more efficient as a consequence of the pandemic? Or does it, as Francesca suggests, that we've recognised the need to invest more in healthcare as a preventative tool, and so that trajectory might move to GDP plus 3%. I find it interesting, the focus upon how we respond to pandemic. I drew the analogy a few weeks ago in our workforce about Y2K, and then 10 minutes into my analogy, I realised for a lot of our people, they didn't know what Y2K was because they hadn't been born yet or they're only still at school. But I invoked the example of Y2K as, we need to be better at responding to Y2K, cybersecurity risks and so forth, but much more than that, we need to be good at preventing the incident in the first place. And certainly our focus as a company, and I think the private sector will lead this, is that finally we move towards a paradigm where prevention actually becomes at least as important as cure. And we become as much healthcare systems as we have been sick care systems for the past millennia. What COVID-19 has done on that front for us was provide some momentum and accelerate the kind of investments that we think are needed around disease prevention and mitigation rather than just disease response and treatment. We're quickly entering a world where, courtesy of artificial intelligence and machine learning, and you guys all know this, that our ability to predict risk at an individual and population level is increasing quite dramatically. And the kind of science and technology needed to do that, we're investing in. We're doing it in collaboration with Cigna, who are a large US-based global health insurance company. We're very deliberately, culturally thinking of ourselves as, we're still a private health insurer, and we'll still be there for people once they're already sick or injured. But we want to be as relevant to people in terms of our ability to help them and their doctors predict risk at an individual level, and with that, hopefully prevent the disease or better manage the disease, or more precisely treat the disease in this world of precision medicine. So certainly for us, a big consequence of COVID-19 will be to accelerate that investment and hopefully that momentum. Another feature, I think, for us of COVID-19 and what consequences it's going to have for us and our industry is the investment we need to make in digital engagement. I rather suspect it will seem very odd to our great-grandkids, or maybe even our grandkids, that once upon a time, what, you're really sick and you saw a doctor in person and you sat in a waiting room with all these sick people, that would seem absurd to future generations. So creating the technologies which, beyond prediction and more precision medicine, enables people to connect with the healthcare system, to be treated at home, to be monitored at home, to be diagnosed at home. Those technologies are going to come faster than what we would have imagined they would pre-COVID. And we've seen that even in respect of virtual consultation at the moment. So we're aboard that train, and of course, while nobody celebrates the suffering and misery and tragedy for so many of COVID-19, these have created real tailwinds for a better, more efficient and risk-orientated system. I just touched upon the point there. Our other forecast is, and investors in hospitals aren't excited about this forecast, but I think inevitably we see a shift away from institutional hospitals of the scale that we've known them to be for the last 100 years towards more home-based settings of care or more specialist distributed lower cost settings of care. It was only a bit over 100 years ago that most healthcare was practiced at home, and I'm old enough now to remember the local doctor coming to visit me at home when I was sick. So we think that's a major trend and a major consequence that we expect to emerge. Now, what broader implication it has for the healthcare system in Australia and New Zealand, a system we know well, I rather suspect we will see an increasing shift towards private settings, away from public settings, if only for the reason that a growing dependency ratio of older people to younger, tax-paying people is burgeoning. Eventually, as a society, we run out of sufficient younger tax-paying people to fund the older, mostly sicker Australians and New Zealand. And those pressures are already being felt across our healthcare systems. It's not unlike, I suppose, the predicament we found ourselves decades ago with the age pension, where Commonwealth funding was being stretched to fund the burgeoning obligation of age pensions, and Australia very deliberately put in some policy settings to encourage people to provide for their retirement in the form of superannuation. And of course, we've seen that with healthcare as well, with the various sticks and carrots, to borrow today's theme, that are applied to encourage people into to private health insurance. So again, while stressing COVID-19, the pandemic has brought joy to nobody. It's an ill winner turns none to good, and we do see opportunities in how this pandemic is going to force certain changes across the sector, and a shift in thinking across the sector away from how do we respond to disease, which will always remain important, but as importantly, how do we predict and prepare for and mitigate the risk of disease at an individual and population level.
Thanks, Mark. Very interesting indeed, and it's clear that there is a lot of opportunity, a lot of things happening. What's less clear is how they're being sort of connected, I would say, and that's probably part of the challenge. I think from these two first initial thoughts, or let's say talks or presentations, however you want to call them, what I hear is that certainly there is a recognition of a problem that sees or calls for more support, that also identifies as, let's say, global, I would say, dimension, perhaps even of governance that is structured in a different way. And at the same time, there are some initiatives that are occurring on the ground that are private sector driven, that will certainly find their space, and as Mark pointed out, and some observers have really supported that view, that could be an important part of the solution. Obviously, what that raises is how that will really materialize in practice, and what tensions and how we will deal with the tensions, like the emergence of two-tier systems, the governance challenges that we always face, not only in Australia, which is clearly an example of a multitude of players. Some even call the Australian healthcare sector as a composition of different systems between states, the Commonwealth, of course, the private health insurers and private providers, primary care funded centrally, hospital care funded at the state level. and so on. So to understand a little bit and put based on what both Francesca and Mark have brought to us, and the reality of our current organizational system, I would like to call on Professor Gillespie for a perspective on this. There are some tensions clearly that have been observed during the first part of the pandemic in terms of how to respond, who's in charge, and also in the vaccine rollout that have really, at least in my view, highlighted some of our sort of fragilities in terms of governance arrangement, and how does that fit with the global trends and the global visions. Professor Gillespie, please.
Okay, thanks, Francesca. Mark's talked about the sort of high-end consequences of it in new forms of practice and that sort of thing. But the initial Australian response was exactly as in 1918, 1919, and to shut borders. And that's really been the core of our response, has been border control, both between states and between Australia and the rest of the world, with a quarantine system probably run much worse than they did in 1919 when they actually were running it nationally. So that's been one end of the Australian response that's been quite different to much of the rest of the world, and certainly is a big problem still about how the states that are doing this so successfully that they've barely had a case are actually going to come out of it. A lot of them seem to be quite happy to move there permanently. But it does raise questions of governance, because it's really the relationship of the federal and states and the split that Francesca referred to in health policy between them, and the difficulty of getting a national response. And a lot of this has been explained in Australia in political terms as a failure of leadership by our current government, and I think there's a strong basis for that. But there are also institutional things there that make it difficult for that coordination to happen. I mean, the federal government had a very effective economic response, and I think some previous leaders would have used that as the means to push federal leadership in areas where the states have control, so that we would have got, for example, the rules on opening borders between states made more standardized instead of just leaving it to the states. But at that federal state level, it's been, in one sense, a modified success with two problems only in two states. On another, it's been an administrative failure of our system. If you look at how public health is organized, we've seen a real natural experiment in how public health, particularly decentralized public health systems, operate, particularly between the two states that have had breakouts, Victoria, which had a much more centralized system, and New South Wales, which had a very decentralized system. And at a low level of infection, certainly up till the Delta variant, the New South Wales model worked very well. And that had developed over quite a long period with experienced public health people who'd really developed it originally out of a big Legionnaire's disease outbreak. And most of those about 15 years ago, and most of those methods were honed over that period. And we was for a long time, again, using methods that would have been familiar in 1918 of track and trace, until genomic testing came in, and a much higher level. We had telephones, but that was about our only advantage. So the health systems worked quite well. The very centralized Victorian one didn't. The governance system worked well at that decentralized level. Where its biggest failing was a problem that's happened in every country with an outbreak, and that's with vulnerable and marginal populations, and the failure to engage them in public health. And we've seen in Victoria, particularly with immigrant communities, particularly some African and Middle Eastern, in Sydney, Middle Eastern ones in southwest Sydney, and particularly recently Aboriginal communities in Western New South Wales, a complete lack of understanding about how to communicate, deep suspicion often from those communities, but a failure to understand the resources that they could bring and could mobilize around it. So I think that public health level, a lot of it's about governance questions. And it's the thing that we're going to have to work out is how to actually develop a national approach to these problems rather than a scattergun state by state one that has worked, but so far, but with another more virulent variant, the whole thing could collapse, like as it started to with the Delta variant. So I think the success of Australia looked at comparing other countries has been luck and some good systems, but ones that are inherently fragile and need to be worked on. And it's been a very inwardly looking one. It hasn't engaged, just beginning to engage, I think, regionally as governments are realizing the sort of complete disaster unfolding in Papua New Guinea and the problems that will have across the Torres Strait if new variants emerge there. So I'd leave that with that mixed picture, concentrating on the public health side of things.
Thank you, Jim. Yeah, very interesting. So important perspectives with of course, the global, the private and the public side of things. Now, to me, what's becoming clearer is that by and large, you can observe not only in Australia but globally, you can observe these contracts between the global size of the problem and the even in some big ways the issues in the global coordination, even during the vaccination rollout. And I will get back to Francesca also to catch what she thinks about that. We have a new opportunity with G20 coming up to fund more resources, to relax some of our international agreements, to allow for better circulation of what's needed to actually produce and get vaccines to the developing world and so on. So you have those issues dealt in a certain way. And at the national level, you have these governance tensions, and often these are happening between regions. If you take European countries that have lighter form of federalism, but still with a lot of devolved powers to the periphery, like Italy or Spain or other Scandinavian countries, or even Germany, which has a stronger form of federalism. With the central, let's say, response, with, of course, a division of powers that seem to really work intermittently and clearly come into crisis when the stakes were higher. And clearly Delta unveiled that to quite an important extent. So I would like to welcome Andrew and get his sense on a question that comes after that summary, which is, what are we likely to see, Andrew, going forward, or what you would like to see going forward, given these various layers of governance power and ability to respond between the local empowerment propositions, so decentralization, versus models that actually devolve, or according to subsidiarity principle, more towards supranational or national organizations, as there seems to be globally a tendency to call for these, as the Monti report and other reports came advocating for more coordination, which to be effective needs to be empowered. So Andrew, what are your thoughts on that? Thanks.
Thanks, Francesco. Before I get to your specific questions, let me make a couple of preliminary remarks. Health systems are huge. You know, even the Australian one at 10% of GDP, it's an industry, and it's not like a program or a system that just simply can be run by governments. Governments help to shape them, but don't actually run them. And the extent to which they intervene to shape them varies from country to country. But just remember the scale of health systems. The second point I'd make, when I look at the COVID response in Australia, I think, you know, as Jim said, our record is that in health terms is very good. I mean, in terms of infections, hospitalizations, and most particularly death rates, we are very much at the front. Clearly, we made some mistakes, particularly around supply of vaccinations and mixed messages about their safety. But as we were coming out, there were genuine dilemmas for governments to try and manage. How do you, given our success in limiting infections, that reduced the incentives for vaccination? How do you then manage that trade-off as you moved up to your vaccination rates? When do you relax your restrictions? The other comment about that is that I am concerned that we don't enter into these restrictions as a matter of course. These are really very strong powers of government. You want to make sure they're only used in emergencies. So the sooner we can move away from them and make it clear that we're not just going to introduce them willy-nilly, we're going to be much more careful, I think is important. Let me now turn to your particular question about the governance and the governance lessons. It's an age-old problem of government, not only in health, but in other areas, that you want both coordination and you want capacity for regional, local management to respond to local circumstances and preferences and so on. If I look at COVID, while the state and territory action was important and generally they've been effective, the Commonwealth coordination, I think, should have been a lot firmer. That needed state and territory input. So the Commonwealth shouldn't act alone, it should get input, but then it should take the lead and say, this is what we're going to do, in particular about quarantine, vaccinations, contact tracing, the stage restrictions and things like that ought to have been led, in my view, from the Commonwealth. I'm a little bit surprised that they didn't do so, in that there was quite a lot of work done, I think around about 2005, after the SARS event, where there was a lot of modelling about what should we do when there are new pandemics. So it's not as if the Commonwealth was totally caught by surprise. They'd actually done some work. You also need national leadership for the stuff that Francesca Colombo is saying. If you're going to be participating internationally, you need the national government there. They need to be there and engage with other countries. So the national government can't just let it be done down the line. That said, you do need local and regional. And I guess my disappointment with this, I was interested in Jim's comment about the natural experiment between New South Wales and Victoria, but not even in New South Wales was there much use made of the regional networks of primary health networks and the regional networks of hospitals. You would have thought that that machinery could have been used a lot more. I think the Commonwealth has allowed their primary health networks that they fund to be too independent of them. Personal view is, I think there should be some health department bureaucrats there working with them and helping them and helping them play a much stronger role, including with the state hospital networks. So I think we could do the regional side better, and I think it's very important, and it could be done with Commonwealth links involved. Let me turn a little bit to Mark's points, the governance issues about public and private. And of course, we've got a rather unique and complicated system. I think looking at COVID, that, as Mark was saying, worked quite well. There was a bit of pushing of the private hospitals around, which did affect the entitlements of the privately insured people, but it hasn't been a disaster. In fact, it's worked reasonably well, and the impact has been reasonably modest, but some impact. But I think if we really want to get this right, we really need to think further about what is the role of private health insurance in our overall system. And if NAB and the other private insurers are going to move more into preventive health and more at the front end of how they work with their members, we need to rethink, how do we subsidise them? What are their responsibilities? If we think they could take more wider responsibility, I think we ought to be looking at a slightly different model in the way we fund them. So I guess I'll leave it there, but you and I, Francesca, have talked before about other models for funding private health insurance. A radical change is going to be too hard, but some modest change to give the private health insurers a slightly wider role with vis-a-vis their members, but with a different form of government subsidy for the way in which they do it. That would seem to me a pretty sensible move.
Thank you, Andrew. I think this is very interesting direction in which the discussion is developed. So I'd like to go to all of you, starting from Francesca. Of course, feel free to make any comments. I mean, I'm just trying to keep a thread, but feel free to take this in other directions. So it seems to me, and I ask this really to all of you, that perhaps, you know, and this is one of the fears that many have manifested, and I certainly share it, that you know, once the vaccine roll out and once we gradually get out of COVID, so to speak, and speak about post-COVID, you know, we can quickly sort of park what has happened and go back to business as usual. So instead of thinking in that way and trying to think in terms of opportunities to reorganize and reinvent and perhaps even do things differently, one provocative thought might be, well, COVID, one thing that it has shown is that it's not the first pandemic. One could conclude, and it's not necessarily just a provocation, that it is, you know, government failure. In some countries more, in some countries less, or in some countries government's failure, depending on the degree of surprise that COVID played in the very beginning. Then, you know, information was shared better. Nevertheless, we still saw failures to some extent. You know, some, when this argument is made, you know, put their hands up and say, yeah, but it's a pandemic, and I'm not quite satisfied with that. If that's the case, that we conclude that fundamentally there has been an issue with governments failing, what other new ideas can we think of in terms of different ways for governments or not governments or multi-sectoral forums to really start cooperating? Because you know, instead of having a private takeover, maybe the private health insurance could have been brought to the table and organized the funding at the very beginning of the pandemic, something that has not happened even in the second large outbreak that we had here. And similar responses have happened, kind of repeating themselves, showing the weaknesses for sure, but also the decisions about government response and capability to do it. So instead of boosting the funding for let's say the old ways, what could we think? I mean, some ideas. Francesca, please.
Francesco, you have put so many things on the agenda, but definitely, I mean, definitely there is an awareness that we cannot go on business as usual. That it's quite clear, and even those reports are mentioned too. I mean, they called about, so let's try to have a, you know, a Chernobyl for health. You know, that's what Helen Clark has been saying. You know, this is a once in a lifetime, hopefully pandemic, but also a once in a lifetime opportunity to change things. So there is definitely a window of opportunity, but there is also a realization that the window of opportunity might be closing soon. Some of the countries, particularly, you know, obviously Australia has been less affected, but some of the countries that have been also more affected are now going back to a more business as usual. It's things have reopened with some exception of the use of masks in a number of countries. Things are back to what they were. And so in a way, there is a risk that the attention and the discussions about making changes to the system might actually, move away as other governments' priority come in. Now, the only thing is that most of the countries are confronted with a huge scale of debt. And that calls for having not just more investment in health, but also much more value for money and reducing of waste in health system. And that is something which is quite clear. And that calls really for thinking about different models. So definitely the issues of having a much greater investments into a public health preventative measures, which needs to be incentivized probably in different ways, depending on the governance structure that each individual countries have. But that definitely is still there. The difficult question is, how do you change structures and governance models, which are incredibly rigid and difficult to change. I mean, the organization of health systems relative to other sectors of the economy is much more rigid in the way it's funded, in the way, if you think also about the skills of the health professionals and the very defined roles that they have, in the way of knobs in Australia with the state level funding as well as the Commonwealth and so forth. It's incredibly rigid system. And so while there is definitely a realization that we need to break those barriers, there is also a huge scale of the challenge in trying to change that in a context in which even the global attention to addressing the pandemic might be gradually going away, and people are a little bit sick and tired of hearing about pandemic. They want to move on to something else. So I'm optimistic, and I think that what I see in a number of countries is definitely discussions about making reforms. Whether those are structural reforms, it's probably less of it's a big question. But there is definitely a window of opportunities. I'm optimistic that things are happening. At the same time, yes, as I said, this window of opportunities might be closing quite sooner than we expect.
Thank you. Mark, please, some remarks.
Well, I think governments by and large haven't failed in their duty. Like, this could have yet turned out to be a pandemic every bit as destructive as a bubonic plague was in Europe in the 15th century. So look, they bumbled around a lot, but failed fast and learned quickly. And so I wouldn't be overreacting to the pandemic, which is not to say that whole health policy, as Andrew says, doesn't need complete reform. Andrew, in my world, there are no subsidies. In my world, everyone has to have health insurance, as they do in Switzerland and the Netherlands, and the money follows the client on an equity basis, and people have a choice as to have a public carrier or a private carrier, just like we're applying with the NDIS. So look, I wouldn't overreact to the pandemic. I think there are deeper structural issues which were already playing out well before the pandemic hit. So what I think the pandemic will do is really shift emphasis out. I've touched upon a few. For me, there's 4 that stand out. An emphasis on disease management. And look, we're not just talking about communicable diseases here. We all know the real burden on society is non-communicable diseases. So perhaps that lights a bit of a fire, which gets us as interested in the degenerative diseases of affluence, as one author once called them. And we're certainly up for that. I think we're going to see necessarily a greater emphasis on primary care. I think we've lost our way with primary care in Australia and New Zealand. It needs to be put back at the centre of care. I think we need to focus more on a lot of the disease burden of society today. You all know well is as much about social determinants, behavioural determinants of healthcare. So in those societies, and say even modern USA, which are suffering, it's not because of medical issues, it's because of poor neighbourhood degradation, unemployment, all the kind of behaviour and the social determinants we know which influence healthcare. And finally, it's going to require a shift in investment more towards prevention. We have a small joint venture in China with quite a large pharmaceutical company, a traditional Chinese medicine, TCM pharmaceutical company. But they're a $10 billion company. They're a very serious business. Now, I haven't been up there for a while because of COVID-19, but we're still getting presentation. The investment they're making in pharmacology and biotech is just amazing. Like, people think about Silicon Valley and the big Americans, but the Chinese recognise that the future of healthcare is going to be about precision medicine and designer drugs and designer treatments. And if we are going to seriously mitigate and wrestle with these kind of pandemics as they emerge, we need to lift our investment, and that investment will come from the private sector, ultimately, I suspect.
Yes, I'm in this feeling too. James, please.
Yeah, I'd agree with Mark that everyone, including all the public health people working in it, would like to never hear the word pandemic again. And probably the best way of preparing for it is strengthening health systems to handle the day-to-day problems of health, rather the way Mark has been describing. I don't think we can just dismiss future pandemics. The economic historian Adam Tooze has described this as the first crisis of the Anthropocene, and environmental historians have talked about a sort of accelerated history since the Second World War of human interactions with the environment, which has opened the way to this sort of interaction. And the pandemic we've just hopefully coming out of is not the one that was being predicted. I mean, our plans, pandemic preparedness plans, were all for avian flu, which could well be just around the corner. And I think preparing for it is partly about strengthening health systems. The second thing is that I think something that Andrew really picked up was we can't do this again. The sort of public health interventions, the very authoritarian ones we've had, are really designed for something like Legionnaire's disease, isolating it, closing it down, solving the problem, then we move on, maybe in a matter of weeks, certainly not in 2 years. We've never done this before, and our population's been incredibly, some would say passive, others would say there's a strong social conscience. And our governments have sometimes been stepped over the line of authoritarianism, and the fight going on in Victoria at the moment over the new public health laws are perhaps a measure of that. So the question of how we respond to something like this without losing support of the population, I think, is going to be a big question, because we just cannot do this again. I don't think we're going to get, I think the support is waning, and governments are recognising that at the moment. So that element of consent is a really important one. So it's really preparing the system and looking at those weaknesses, and looking at, for example, in every country, I think the health social care nexus is going to be an important one to look at, and health and aged care. And I think those were weak points here that never were under enough pressure to completely collapse. But we saw in Victoria, the first breakout, almost everyone who died was in aged care. So building those connections, strengthening the public health system, and I think that Andrew's point about regional and particularly the connection of primary care to the rest of the system is a central element in that. And that, as he said, failed in this case. So I'd say it's that mixture of system strengthening and hoping that we're not going to be faced with this sort of rolling crisis, because I don't think our current systems can handle it.
Thank you, Jim. So Andrew, some final remarks, please.
Yeah. Let me respond first of all to Francesca's comments, because I thought they were particularly valuable. When you're thinking about developing countries and the need for them not just to go back to where they were, I think trying to convince them to put more investment into primary health is important. If I look at countries like China, who have got enormous improvements in their health system over the last 20 years or so, but the weakness is still at that primary health level. And you need primary health level, particularly for purposes of prevention arrangements. So I do think if I was looking at developing countries, a lot of them are weak on primary health, but stronger on acute care, though rather mixed. But the second one Francesca mentioned, I think, is equally important, that for a lot of developed countries, including Australia, we've now got a very big debt. And the shift in the debt burden will lead to pressures to be more efficient in our expenditure. And health systems are not renowned for great productivity gains. And trying to work out ways to get them to be more efficient. Flexibility is one aspect that Francesca mentioned, but trying to think about whether there are ways through purchase providing or other frameworks which might put some pressure on efficiency, trying to get the allocation of resources in a more efficient fashion. I think that agenda is an important one. And I think Australia has not done much on that for the last decade. And I think renewing that agenda. One element of that may be to rethink some of the way in which private health insurance and private hospitals work with the Medicare and the public hospitals. And Mark made a criticism of me about using the term subsidy. Let me make it quite clear. I do not object whatsoever to money going to private health insurance in respect for those activities they do, which would otherwise be done by Medicare. But we don't do it that way. We have a very messy system of making those payments. And if the private health insurance system were to take more responsibilities for their members, and I think they want to and they could, well, then you would redesign the money accordingly and you would have a better role that way. And that may be part of an agenda with new incentive frameworks, which might actually help us push for a greater efficiency.
Yeah, Andrew, we're doubly insured. We're insured in the social insurance system and the private system. Well, half of us are at least. So no, I wasn't sensitive to the point, promise you.
Fantastic. No, this is very good note to bring to a closure. So I would like to thank you all. I would like also to mention, before I thank you, the contribution from the chat. Certainly, Professor Minichiello was mentioning the importance of a real social license. So speaking and anticipating, actually, this was made early on to what basically James was mentioning. Again, later on, the importance of actually having, I would say, thinking that really speaks to the people without having them on board, that there is certainly a risk, and this also brings in the need for social design of whatever comes next, which I think is important to mention. So I've received other points as well, and we'll get more certainly as usual when this plays in our channel. So I wish to thank Francesca for being with us today. Have a great day in Europe. We miss you very much, and we hope to come soon. And Mark, thank you so much also, and well done on being innovative on the work front, allowing remote work under some conditions, and great pictures on the family on LinkedIn. I loved it and distributed to all. That is the bright side of being able to work from home, creating connectivity in a new way. Thank you James Gillespie for being here with us from Sydney. Hope also to catch up very soon. And Andrew from our capital in Canberra. Thank you for joining us. And finally, thanks for the Vice-Chancellor, Professor Upton, for opening and hosting this event. For those who are here and those that will connect later on, as you know, the special issue on Elsevier's health policy and technology is soon to come out. So watch our website of the Value and Health Economics and Policy group. And of course, also be connected to our next events next week, focusing on the implications on labor of the current pandemic. And late in November, which will be our last event, we will talk about digital health and what really is happening, which is a fundamental revolution now we're thinking about and doing healthcare. So once again, thanks for joining us. Have a good day, everyone. Bye.